I'm going to begin by going over our hospital's admission form as well as release and consent form, as this is a combined form for us. So our admission form begins with an area for the client to fill in their personal information, such as mailing address, their name, and also a spot for them to give a phone number where we can reach them at on that day if we need to get a hold of them. Beside it, we also have an area for the patient's signalment. So we do have room for the pet's name so we can keep track of our patients, the species, breed, what sex they are, as well as their date of birth. We do also, on the side of the form, often jot down their weight, as well as if they've had any medications the day of the surgery, the day before the surgery, and that they are NPO for the surgery. This form then goes on to explain that they are releasing liability by signing the form for a specific procedure. So we do have an area to write in what that procedure is that they are giving permission for. And that should anything arise while they are in our care, if they become ill or if we are in an emergency situation, that they give us permission to do what the veterinarian sees fit to correct that situation, and that we are absolved of all liability, and they have an area where they are to sign that consent. We then have our permanent patient record, and we still use hard copy files for our records. So the nice thing with these files is that we are able to access information really quickly. Right away, thanks to this blue sticker, I know that this file belongs to a dog. By opening to the front page of the file, which has owner information if we needed to contact the owner. It also has the signalment for our patient, so it has the name of the animal, the breed, what species they are, their date of birth, what descriptive features they have, so what color they are, and what their sex is. We also have an area that we can put microchip information, so we know they're microchipped. We also have a quick access area where we can see any vaccines that the animal has received, and we do have an area on the bottom that we can have a quick look to see if they have had any testing or procedures done. And with this medical record, it does allow us to have a quick glance through to see what work has been done on the animal, if the animal is on any medications, and if the animal has had any previous surgeries completed in the past, as well as if they have had any previous lab work done in the past. So having our patient record set up this way, it's just a nice, quick, easy way for us to be able to get all the information that we need to know when the animal's checking in. This is our hospital's cage card. The nice thing with this one is designed to be folded in half so that we have our TPR and preoperative exam information on the first side, and then we have all of our post-operative information on the back side. What is the same on both sides is that we do have a spot for us to write in the kennel number so that we can keep track of what kennel the animal is in. We also have an area for the patient's name and last name, what veterinarian is doing the procedure, and what procedure that they are in for. And this allows us to keep track of our patients because we can compare this information, what kennel they are in, based on what has been written down on the admission form. And so long as all of this information matches with the admission form and with the hard copy file, then we know that we are treating the correct animal. So here are a couple of examples of some of our standard laboratory forms. So starting off, I have some blood work here. This one happens to be a Chem 17 profile with this PCV. Typically for pre-surgical blood, we're doing a Chem 10 profile with PCV. The Chem 10 gives us enough of our minimum database to let us know whether or not we should be proceeding with anesthesia for that animal on that day, or if we have any values that happen to be off that we should inform the owner of, that perhaps we should be postponing a procedure or doing further diagnostics before proceeding with the procedure. Another standardized lab form that we have is our urinalysis form. So both the stick run by IDEX as well as it being double checked through microscopy. This is our hospital's anesthetic form and surgery monitoring sheet. This form allows us to do a lot of things. We do have an area on the form where we can track patient information. So we have the patient's name, the client's last name, what their weight is, their breed, the procedure that they're having done, their date of birth, and the veterinarian performing the procedure. This information does help us track that we are performing the procedure on the correct animal. We then have a pre-surgical area. This allows us to write in what medications we're planning to use as our pre-anesthetic and induction agents, as well as the amounts that we're going to be using. We then have a continued area on this side, which does allow us to jot down if we are using any fluids, so what kind of fluids we're using, what fluid rate they are on, and then whatever post-ops we are planning on using. Our form then also gives us an area to track any additional things that have been requested by the owner, such as nail trims, microchipping, additional blood work, or anything that they would like us to check while they are sedated or in our care. We do then have an area for actually tracking the surgery in 5-minute increments, and it consists of CO2, O2, the amount of anesthetic gas they are on, their respiration rate, their heart rate, their SpO2, their blood pressure, and their temperature. As well as it allows us to track when the surgery has started, when it has finished, and when they have extubated, and the technician that was responsible for the care of that animal. We do also have a little area where we are able to jot down some emergency drugs so that in the event of an emergency, we already have calculated dosages so that we can access them quickly and not have to worry about it. We do on this sheet also have an area that is specific for dental surgeries. It allows us to track how long we are spending on extractions, what degree of scaling is being done, if we're doing dental radiographs, if we're using nerve blocks, for example. This is our hospital's discharge form. So this form goes over everything that we talk about with the client as we are discharging the patient at the end of the day. This allows us to have a verbal conversation with the client, but also have the client go home and be able to read about it if they can't remember what we talked about, because we do find it is a lot of information for owners to remember. So this form does go over the basic aftercare for surgical procedures as well as hospitalized stays. So it informs the owner what to expect, that the typical recovery period is about 14 days, but could be more or it could be less, and it is dependent on the animal. But to expect to have a decreased activity level for the first 14 days post-surgery, that for excited animals in particular, that an effort really does need to be made to keep them calm, that they may need to be crated during the recovery point so that they are not bothering their incisions and that they're not too active. It does also mention how to provide food and water post-surgically, because a lot of animals do go home and they are still a bit nauseous. So it does advise owners to start them with small amounts of water to make sure that they're not so nauseous that they are going to vomit their food, to provide a small meal if they are able to keep that water down, and then typically they can go to regular meal feedings by the next day. In hospitalized cases or foreign body cases, for example, where specific diets are required post-operatively, we will go into that in specific detail. And if it is not on this form, we will provide them with a note about the aftercare as well. There is also a section that mentions post-operative care. So in that section, it does talk about what to watch out for, what to look for with incisions, that there may be some oozing, slight swelling, bruising from the incision, that these can be normal, but what to watch out for that may not be normal, such as swelling, bruising, oozing that is greater than where we are sending them home, if seromas are forming, as well as to not have animals looking at their incisions. It does stress the importance of that animals may be required to have an Elizabethan collar. It does also have a section that does mention pain management, why we are sending animals home with some form of pain management, which could vary for 24 hours or it could be up to the full 14 days. It's on a case-by-case basis, but it does go over pain management for them as well. And then we do have a specific section so that we can mention to owners and check the appropriate boxes if they are required to come back to us for some aftercare. So for example, if a drain has been placed in, we can mark that off so that they know when to come back in to have that drain removed. It also has an area for us to show if they have absorbable or non-absorbable stitches and whether they need to come back and have those sutures removed. And then whether they are going to be starting their pain medications the day of the surgery when they're being discharged home, or if they're starting it the following day. Then at the bottom of the form, it does mention our contact information if they should have any problems, as well as the emergency clinic in our area. A couple of unique forms to us is, along with our admission and consent form, we have chosen on the back side of the form to offer clients some additional services while they're in our care. So additional services can include a complimentary nail trim. We also offer the option of microchipping pets. We strongly encourage that, and we will do it while they are sedated so it's less uncomfortable for the animal. Some other services that we offer is if we happen to find that the patient is a cryptorchid neuter, if the owner was unaware of that, if they give us consent to go ahead with it, then we can just go ahead and do what we need to do to remove that testicle, be it in the flank or in the abdomen. Otherwise, we would have to contact the owner and receive the permission for that. We do also have a section where they will give us consent or not to remove deciduous teeth. We explain the pros and cons we explain the cons really of leaving those deciduous teeth in. And the cost for us to remove those deciduous teeth is actually significantly less than having it done in an entire other surgery. So if we happen to find during our pre-surgical exam that deciduous teeth are in the mouth, then we will just go ahead and take them out if we have consent. Otherwise, we will have to contact the owner. Another form that we have for our surgeries is a laser consent form. We do offer CO2 laser at our clinic. So this form explains the benefits and the differences of using that laser in the surgical procedure and what that can be used for. Okay, so for moving a patient, really the biggest thing is making sure that we provide full support of the patient, particularly if we have a recumbent patient or a patient that is not up and mobile yet. This Rusty here has woken up well from surgery, that he will work well for a demonstration. So just providing full support underneath of him as I bring him out, and then I have full support of him. And we're placing him back in, supporting him until he is well settled on his feet. Good job, Rusty. Look at that, sweetheart. There we go. It's okay, buddy. I'm holding off the back leg for us to pull blood on the lateral saphenous for this dog. Look at that. Look at that. Good girl. I'm just going to hold pressure for a minute so that we don't have any hematomas. So I have Rinslow here, who's going to help demonstrate how to put a muzzle on. So we have a couple different types of muzzles that we can use. We do have basket muzzles available. We prefer to use the nylon type of muzzle in the clinic because it does provide us greater control of the mouth. In cases where there is risk of vomiting or we do want the dog to be able to pant, we will choose to use a basket muzzle in that case. So when choosing a muzzle, we want to make sure that we pick a muzzle that does fit the dog. So in this case, this size muzzle is far too big for this dog, whereas this muzzle is too small. So for this dog, this is the muzzle that I'm going to choose. So I start off by loosening up my strap opening it up, and I'm going to choose to place the muzzle from behind the dog rather than being in front of the dog, in the dog's face, which can be scary. So just from behind, I do have a helper holding the dog. I'm just going to pop it over the head, right on the nose, bring my strap around back, and then I'm going to pull it nice and tight so that about one finger can slide in underneath. And now my dog we have full control over its mouth. We do still have to be careful though, as there is still the possibility that the dog could pinch or nip, but the dog is not able to bite. Okay, so I'm going to be completing a pre-surgical exam on this dog. So to start my exam, I'm going to be working from the nose tip all the way to the tip of his tail. So starting off, I'll have a look at his eyes. His eyes are nice and clear. His conjunctiva look good. I can also check his pupillary reflex. And they are responding normally. If they were responding inappropriately, so if eyes were not dilating with the light, or one eye was dilating and the other was not, that would be cause for concern. Also going to have a look in his mouth, checking out his gum color, looking at his teeth all the way to the back teeth, checking my capillary refill time as well, which is part of our TPR examination. So if his capillary refill is less than 2 seconds and his gums are nice, healthy pink, and his teeth look great, I'm going to have a quick look at his ears. So looking to see if there's any obvious signs of debris, infection, inflammation. His ears look great. No signs of debris, but I can also have a quick look with my otoscope. You just want to hold his head for me to keep that. And his ears look fantastic. No signs of inflammation or any debris deeper down into the ear as well. We can also check our lymph nodes. And check range of motion on his front legs. As we move along, we can feel over his ribs to check for body condition score. So this dog is a little bit on the thin side. So if we were using a 9-point scale, this dog would be about a 4.5. On a 5-point scale, this dog would be just slightly less than a 3. As we can feel his ribs clearly, but not so much that he would be emaciated. This is a very athletic, lean dog. And moving on to our abdominal palpation. The feeling, see if I can feel his liver, which I cannot. He is fairly tense. Feeling for his stomach, which is fairly empty at the moment. Moving along to feel his kidneys. And his intestines, all of which feel healthy. I can also check his inguinal lymph nodes. Because he is such a thin, athletic dog, I am able to just feel them. You can also check his pulses, making sure that his pulses match on both sides. I can check his lymph nodes, the backs of his legs. And check his range of motion. Having a quick look at his bum. checking, this is a neutered male, so there are no testicles. We would be checking if you were a crypt orchid, if you were an unaltered male. As part of our TPR, I'm going to be listening to his heart and lung sounds. So listening to the 3 valves of his heart, which all sound great. Also taking a heart rate and listening for any signs of arrhythmia. So because this is a lean athletic dog, he has a heart rate of 60 beats per minute, which is not bradycardia for this dog. This is a normal resting heart rate for this dog. No signs of any arrhythmias. I'm listening to his lungs on both sides, which sound great. Also checking his hair coat. So he does have a nice shiny coat. His skin looks nice and healthy. No sign of any fleas. And lastly, I'm going to check his temperature. It is best to use a rectal temperature. He is a little bit sensitive about having rectal temperature done, so I'm using an ear temperature for this dog. His temperature today is 38.5 degrees Celsius, and our ideal range is between 37 to 39 degrees Celsius. So, based on our findings in our examination, I would assign this dog an ASA score of A, because he is a normal, healthy dog with no clinical findings. So, he receives a score of A.
talking, Jackie.
Well, maybe your dentistry won't show up because you're not here yet. So that's so sad.
That thing called.
Yes.
She was talking about that cat with the eye. Just want to know if I can wait until 5 days.
Sure.
Yeah. And then Bernie Crosby was in. This cat's like 9.
Good dog. What a great good.
The minimum databases, according to the textbook, consist of the PCV, total protein, blood glucose, BUN, and ALT. The PCV, or packed cell volume, uses hematocrit to help determine the percentage of red blood cells in a whole blood sample. And a low percentage would be indicative of cases such as anemia or an inability to generate red blood cells properly, and as well as some secondary bleeding that may be occurring, such as secondary trauma. High percentages can be indicative of dehydration. So normal ranges that we're looking for in cats, we're looking for about 28 to 48%, and in dogs we are looking for about 37 to 55%. Then we are going to look at our total protein, which can be used with the same hematocrit, which the protein is placed onto a refractometer. And we're looking at the major sources of protein, such as albumin, fibrinogen, and globulin. And this can be indicative of the serum oncotic pressure within the body. Low values can be indicative of an inability to properly generate these proteins, whereas high values can be indicative of dehydration, as well as some malignancies. And normal ranges that we're looking for is 6.5 to 8.2 grams per deciliter in cats, and in dogs we're looking for 5.5 to 7.5 grams per deciliter. Then we're going to be checking the blood glucose. Blood glucose gives us an idea of the function of the endocrine portion of the pancreas, as well as carbohydrate metabolism. Blood glucose is particularly important to check in geriatric and juvenile patients, and it may actually need to be checked intraoperatively as well. Blood glucose results can be affected by stress as well as fasting for procedures, so we do have to take that into consideration as well. Normal ranges that we're looking for in a dog is about 80 to 130 milligrams per deciliter, and in cats it's 70 to 180 milligrams per deciliter. Anything less than 40 milligrams per deciliter is considered hypoglycemic, and we would need to intervene in that case. From there, we are also checking the BUN, which is blood urea nitrogen, and that helps us determine kidney function. If the nitrogenous waste that's being produced by the liver is being treated properly by the kidneys and being removed from the blood. So elevated values of the BUN indicate that there is something going on with the kidneys that may warrant further attention. We are also looking at the ALT, which is the alanine aminotransferase. It's not the most indicative of liver disease and failure, but elevated values can indicate that there is something going on, that there is damage to the hepatocytes, or that there is something going on with medications that an animal may be on. So the database that my clinic chooses to use for a pre-anesthetic blood work is the Chem10 profile by IDEX along with PCV. This one is actually a Chem17 profile, just as a sample that I have here for today. But typically we would be running a Chem10 profile, as that does cover our minimum database, as well as providing us some values, a couple extra liver and kidney values, which can help to give us a bigger picture if anything happens to be off. And based on that, we can make the decision to either do further diagnostics if needed, postpone a procedure, go ahead, or to perhaps take a bit more caution with the planned procedure. So I'm going to discuss our pre-anesthetic and anesthetic protocol that we use in our clinic for the majority of our patients. So we begin with using a combination of hydromorphone and dexmedetomidine or dexdomitor as our pre-medication. The hydromorphone is given based on the size of the animal. If they are over 10 kilograms, they receive a concentration of 10 mgs. If they are less than 2 kilograms, then they receive a diluted concentration of 2 mgs. This is given at a dose of 0.05 mgs per kg. We choose to go with the lower dose with the hydromorphone, as this allows us the ability to bump up that dose towards the end of our surgery if we feel that the patient is in a bit more pain than we were expecting. Then we can give the remaining 0.05 mg per kg at that point towards the end of surgery. So this pre-medication is combined with dexmedetomidine, which we use the charts provided by the company. Lower end doses for calmer, quieter animals, higher end doses for animals that are a bit more excited or stressed out. This in combination is given as an IM injection, and this gives good pre-anesthetic pain relief as well as providing some sedative effects. For induction, we choose to use propofol, which is at a concentration of 10 mgs. In terms of the dose that is given to the animal, it is dependent on several factors that we have to take into account when calculating this drug out. It depends on what the species is, are they a dog or a cat, as well as are we using it as the induction agent or are we using it as a sedative for a quick procedure, in which case we would need a higher dose of the medication. So when we're using it as an induction agent, we tend to use slightly lower doses. So once we've calculated the correct dose and have used it to induce our animal, we have intubated them. They are then placed onto our gas anesthetic, which we use isoflurane. Because we have already given some preoperative pain management from both the hydromorphone and the dexmedetomidine, this allows us to keep our anesthetic concentrations relatively low, ideally at around the 2% mark or lower if possible. Some cases we do have to keep them a little bit higher if they are a bit more painful, and in those circumstances we can choose to give that extra dose of the hydromorphone if needed. For general post-op pain management, we do choose to give a dose of Metacam or Meloxicam at a concentration of 5 milligrams at a dose of 0.2 mg per kg. Thank you. I'm going to be placing an entry into our controlled substances log. So today I'm going to be placing our hydromorphone 2 milligram into our log. So this dog is going to be getting a dose of 0.2 milliliters. So in our log, our page is full, so I'm going to go to our next page. I am placing the date, September 8th, 2015. I'm writing the patient's name. Followed by the veterinarian who's performing the surgery, the technician who drew up the drugs, the amount that we are removing, which is 0.2 milliliters. And then we are going to balance our log. So our previous balance was 3.44 mils. So our new balance is 3.24 mils. Going to talk about our anesthetic machine, starting with our oxygen H canister. Turned on at the moment. Our pressure is beginning to run a little bit low. Ideally, it should be at about 2,000 psi on our pressure meter. We then have a flow regulator. Coming over to our machine, we have our oxygen flow meter, which allows us to control the amount of oxygen being delivered through the system. We have our flush valve, which allows us to place pure oxygen into our system. We have our precision vaporizer, and we use isoflurane. Then comes up to our unidirectional inhalation valve. Any excess gases will fill into our reservoir bag. This bag is also handy if we need to do manual ventilation and ventilate the patient. Inhaled gases then come through our corrugated Y plastic tubing, and our exhaled to this side to our unidirectional exhalation valve. We then have our pop-off valve, which typically for a rebreathing system would be open to allow pressures to move through. If we are to close our pop-off valve, for example, for manual ventilation, we do need to take care that 20 centimeters of H2O is not exceeded on our manometer. Any gases that are moving back through our system are then going to be scrubbed through our CO2 soda lime scrubber. The granules in here will begin to turn purple as the product becomes saturated with CO2 and is at the expiry point. So our pop-off valve does need to be opened back up so that exhalation after manual ventilation can occur, so that gases move through our scavenging unit and are then taken to our scavenger on the wall and then out of the building. If we are doing a leak test, our pop-off valve is going to be closed. I am going to hold on to the end of my Y-piece tubing, capping that off, and I can flush oxygen through our system, and a positive test should show that our reservoir bag is holding the full amount of gas and that it is not seeping out until I release that pressure. So that is a positive test. We have no leaks in our system. For a rebreathing, or a non-rebreathing unit rather, our scavenger attaches directly to one tube. And isoflurane and oxygen are directed to another. So we no longer require this rebreathing bag. So this is our non-rebreathing system. Typically this is used for animals that are less than 8 kilograms. We do need to make sure that our pop-off valve is in the open position so that gases can move freely through. If manual ventilation is required, we can close our pop-off valve and then open it as the gases are exhaled. So the difference with this machine is that none of the gases are being reused, scrubbed, and circulated back through. Every inhale brings in a new set of gases and exhales pushes gas out. So if we are to run a leak test on the system, again, we close our pop-off valve. I cap off the end of our piece, use our oxygen flush, and our bag should be holding its charge, which it is, until I release, and then the oxygen is released. So the tools necessary for us to induce anesthesia are an anesthetic machine. We also are going to need a laryngoscope to help us place our ET tube, and our choice of blade size would depend on the patient size. Our ET tube is also going to be dependent on our patient's size. To measure our ET tube, it is based on the size of the patient will give us an idea of what range to look for our ET tube size. We can also check the width of our tube. Should be slightly smaller than the space between the nares. And when measuring the length of the ET tube for placement, the length of the ET tube should be from the thoracic inlet to the tip of the incisors. We also have a tie to tie on our ET tube to the patient so that it is secured in place. And then lastly, we need a way to have our patients be moved into surgery. So our table here also doubles as our gurney and can move larger and medium-sized patients into our surgery suite. For anything smaller, we would use a towel such as a sling. I'm placing a catheter into the stock. Starting by shading. Oh, just a little bit bloodless like this one.
Usually it's mine.
Okay, so I'm able to feel my vein, so I will do my prep. I'm doing a 3-stage prep, starting with chlorhexidine scrub.
Can everything be cleaned up there? There's nothing that's
Followed by alcohol.
there's the bruising. Okay. Okay. But other than that, everything disappear.
Followed by betadine. I'm going to be placing a 20 gauge catheter into this dog. I have a flash. I'm advancing my catheter forward. Bringing out my stylet. I'm going to clean. That's great blood pressure.
Right, it was healing. You're still being revolutionary. Yep.
Okay, and I'm going to connect my fluid line to make sure my catheter is still patent. This dog has great fluid, which is going to be right there, and hopefully we won't have another mess. Just put some pressure there.
This I thought for sure it was good. Last night it looked like it said.
Okay, I'm opening my bag of fluids,
Just starting to lift.
which have the fluid has already been run through the line to eliminate any air. And our fluids are running. So I'm going to decrease my drip rate while I finish bandaging. Get my holder doctor to hold my line for me as I tape it. Putting a little bit of tape at the bottom of my line to try and prevent any kinking in the line once it is bandaged.
Hello. Yeah. Well, relief. Can't give depo. Too early. So really only option is leukemia and see if that helps a little bit. And think about maybe
Placing gauze. And I am making sure to leave 2 toes exposed so that we can check for swelling.
if it didn't work with the liquid, I doubt it's going to work with the pills. So remember, I'm out with that.
By my vet wrap, which has already been extended so that it doesn't apply too tightly. Again, making sure that I leave 2 toes exposed.
She's like the spawn of evil. I cat sat her once.
Okay.
She's diabetic. And I couldn't get like I had to get help with gloves to do her. She's like,
What am I doing with her?
I don't know. Check out her teeth. I'm
Check
just
her.
warning you because I don't think you've ever actually seen her clinically before.
Oh, okay. So Haley is the devil.
See, I don't have, with a computer,
Thank you for the warning.
I'd have to look at the pause.
She loves her mom. So
Just
maybe
placing
she
my
better
last
go.
piece of securing tape.
But like,
Yeah,
it's
but-
awful.
Okay. You,
And then doing a last check with my fluids, making sure that they are still running. And our fluids are still running great.
Overgrowing discharge from bone.
So our catheter is placed and it is patent. When checking to make sure that a catheter is patent, there's a couple of things that we can do. First, we want to make sure that our fluids are running, which they are. We can also have a look to make sure that there is no swelling around the catheter placement site of fluid going subcutaneously. So in this case, we do not have any swelling. We can also use a flush by injecting some saline or some of our fluid, which is lactated bringers in this case. By crimping off our line, I can have my holder place her thumb just over the vein so that she can help feel if my flush is moving through the vein. Can you feel that? Yeah. Excellent. So our catheter is still patent. Okay, I hope they wanted a nail trim. Nails are so long. Okay, the nails are pretty gross. Okay, so I'm beginning my prep for my lateral saphenous catheter placement using 3 times scrub, starting with Hibitane, alcohol, and then betadine.
But I'm quite happy to take that because I don't have enough veterinary. now that Shannon's here, we can do, let's do the hernia first, so it'll be off the top of the table.
Do you want to?
Journal, same as if we were gonna
Do like a.
yeah,
Okay.
exactly, so stool off the back.
Perfect. Oh, aw. Just cut off the side of it. It's washable. Doing the bone first.
Should trim some more of his feathers on that side. Attaching my line to make sure that that catheter is still patient with that bandage material. And my fluids are flowing, so our catheter is patent. So I'm turning that back down so that I can finish bandaging my catheter. I'm just going to put a little piece of gauze just to provide some support underneath that.
Well, dogs do patellize different than humans, so you can't.
Yeah, but the dosage
Yeah.
was completely wrong. That was the problem, as soon as I had it in there.
Yeah.
I was lucky to be. Because I love yeah, no, whenever you have, like you were saying, that was working with their Canada.
I'm going to check make sure my catheter is patent one last time, and my fluids are still running well. So we are going to pre-oxygenate this cat for the next 5 minutes. Just placing the mask over her face. The cuff on the mask is just large enough that her nose and mouth fit inside, but not so big as to irritate her eyes, so her whole face is not inside. So we will do this for the next 5 minutes and then begin induction. Okay, so I'm going to induce this cat using propofol as our induction agent.
Yeah. So, how many laps are you gonna Yeah.
I gotta take her.
Okay, here,
9 o'clock. Monday morning,
9 o'clock? Oh, okay.
okay?
Okay, go ahead.
Okay, Jen? Okay. Everybody, 9 o'clock. So where's this lady
So propofol does have the tendency to cause respiratory depression. So because of that, we give it in small boluses to effect.
It's right easy.
Lonnie did one the other day.
On a Dogo Logo or whatever.
Logo.
The curly kid.
She does not have a blink,
I don't think so. She's a student.
and her jaw tone. She does not have jaw tone. She is still breathing.
Yeah.
I am going to give another small bolus.
They're doing a procedure right now.
So I'm going to be giving this kitten a subcutaneous and an IM injection. So doing Metacam subcutaneously, and panaqueous we are giving IM. So for IM, I am palpating along the spine, looking for an intervertebral space, then palpating just beside the spine to feel the epaxial muscle. I'm going to place my needle in 90 degrees, pull back to make sure we have no flash, and then inject. And for a subcutaneous, I'm going to do a skin tent between this animal's shoulder blades on its scruff. Feel for the pocket. Place my needle at about a 45-degree angle, pull back, and then inject. Placing eye lubricant into this sedated cat's eyes. So just placing a thin amount along the eye. And this eye does have conjunctivitis, so I'm being very careful to not touch the eye with my applicator tip so as not to cause contamination. So I am applying 1 spritz of our lidocaine spray. I've already chosen the appropriate endotracheal tube size for this cat. In. Now that my cat has been intubated, they are placing it on oxygen. I'm going to slightly cuff my endotracheal tube. For cats, we don't need to cuff the tubes very much. And one way to tell is if we hear any sounds escaping around the tube, which we do not. I'm now going to place my cat on a low anesthetic rate. Beginning my 3 times scrub, beginning with a Hibitane scrub. I'm using a bullseye pattern.
and then rinsing with alcohol.
Hello? Hi, Jen's just still busy right now.
And our final betadine scrub will be done once we are in surgery.
If a patient were to go into cardiopulmonary arrest during a surgery, if they were presently in a dorsal recumbent position, the first thing we would do would be to place them onto their right side so that their left side is facing up. Immediately chest compressions would begin. If it is a small patient, such as this one that we have for an example today, chest compressions would be with the fingers underneath the rib cage and the thumb on top at the level of the heart. And compressions would be by compressing thumb into the fingers. Compressions should be adequate enough to decrease the chest space by about 30 to 50% at a rate in a small animal of about 120 to 130 compressions per minute. If this were a large animal, the hands would be placed on top of the level of the heart and compressions would be with full force with straight elbows down onto the chest. For larger animals, compressions would be at a rate of about 100 compressions per minute. So while someone is completing chest compressions, if the animal is not currently intubated, ideally the animal should be intubated. If not on an anesthetic system, the animal should receive breaths through the use of an ambu bag. So the ambu bag would be connected to that endotracheal tube, and breaths would be delivered ideally by someone else at a rate of about 8 to 10 breaths per minute, and just gently depressing the ambu bag, which delivers room air to the patient. Now, with chest compressions, ideally, whoever's performing the compression should be switched out every 2 minutes, as compressions can become very tiresome, and compressions are what is allowing blood flow to occur in the patient in absence of the heartbeat. So very important that the chest compressions take priority and that they remain consistent throughout the event.
Okay, so I'm turning this cat off of anesthetic and oxygen out here so that we may begin transport into surgery. And I'm going to be slinging this cat into surgery, taking care with my prepped area. So now I'm going to secure her to our table using lead ropes. And our surgery table does have little devices which hold on to these ropes for us. Now that we have her all attached, I have placed sterile gloves so that I can complete my last sterile betadine scrub. Again, using a bullseye pattern, making sure not to go over the same area twice, working from the inside out.
are now prepared to begin surgery. Beginning with my ECG, touching my left leg, my left arm, and my right arm. And then placing alcohol. I'm going to follow by placing my esophageal temperature probe. My SpO2 monitor, which I'm going to be placing on the tongue. And choosing the appropriately sized cup. So for this cat, I'm going to choose to use a size 2 cup. Should be about 40% the width of their arm. My esophageal stethoscope, measuring about the length that I will need to the position of the heart. Applying a small amount of lubricant. And then into the esophagus. Because our endotracheal tube is already placed, it cannot go down the trachea, it can only go into the esophagus. And I check for heart sounds. We have heart sounds. And this is our capnostat, which records both our CO2 readings as well as our respiratory rate readings, and we have it linked in with our anesthetics delivery system. This is our anesthetic monitoring sheet. So we do our monitoring checks every 5 minutes. And the parameters that we are checking for, we are checking on their CO2 levels, we are checking on their oxygen levels. Now, because we use a ventilator, our oxygen levels are preset by the machine. So these are the oxygen levels from the ventilator. We have our anesthetic levels when we use isoflurane. We have our respirates, which again are set by the ventilator. So sometimes we can have lower respirates around 5 or 6 if we have large-sized dogs, but because the ventilator is controlling how much oxygen is pushed into their lungs, this is okay. We then have our heart rate, our SpO2 or pulse oximeter, our blood pressure, and our temperature readings as well. And all of these parameters are going to be checked both with our monitoring equipment as well as by actually checking out the animal, listening through auscultation, listening to their heart rate, listening to their lung sounds, and checking their eye roll as well as their gum color and CRT. So this is our Cardell monitor that we use to track our vital signs. So at the top here we have our heart rate. This is a good heart rate for the size dog that I have at the moment, which is being read with our ECG leads. We have our SpO2 or pulse oximeter monitor. We have 100% oxygen saturation, which is fantastic. We have our blood pressure reading. A blood pressure reading of 82 is great. We get concerned if we are getting readings anything below 60, as there is not enough perfusion to organs. We have our CO2 reading from our capnostat as well as our respirate. So our CO2 is in a good range. Ideally, I would like to get it just a smidgen lower, but we are okay with that. And our respirates are great right now. We do use a ventilator in surgery, so the respirate is controlled by the ventilator. We do also have a temperature monitor, so her temperature is currently 38.1. So this lets us know if her temperature is getting a little low throughout the surgery and if we need to warm her up, either during the surgery or after. So to confirm the values from my monitor, I also double check by listening to the heart with my esophageal stethoscope. Taking heart rate, listening to breath sounds, and listening to the heart itself, which all sound great. I check the eyes, make sure that they are rolled ventrally, which they are. And I also check gum color, so we are still nice and pink, and our CRT is still less than 2. Now I'm going to begin my scrub, and I'm going to be doing a 10 swipe scrub, where I'm going to scrub every surface of my hand like a square. It's 10 scrubs. Getting my scrub on the other hand. I'm going to rinse off my hands, beginning at my fingertips, working down to my elbows. I'm allowing the water to drip, and I'm going to open up our sterile hand towel. Letting the towel fall and open on its own, and then begin drying the tips of my fingers. Opening my gown. Rolling my gown and fall forward on its own. So how long do you want to how long is it in perform closed gloving. I'm going to be placing the drape for our procedure, picking my drape up and allowing it to fall naturally without touching anything. We are using a pre-fenestrated drape, and I will note that we are doing a laser procedure, so it does not appear as though the animal has been scrubbed, but it has been scrubbed with thermostat and LRS. And I'm gently placing my drape, being careful not to touch the animal or the table. Done. Prepare our tray for our surgery, placing everything as per where the veterinarian prefers them. And opening the second layer of my sterile surgery pack. Placing the instruments that we do not use frequently off to the side. The instruments that will most likely be used towards the front of the tray. Along with a pair of scissors, my needle drivers, thumb forceps, and scalpel blade. To place my scalpel blade onto my scalpel handle. Okay, so I'm going to block bleeding and just gently dabbing and removing my gauze. Never wiping at the area that's bleeding, which can remove any clotting that's occurred and cause further bleeding. So for moistening tissue, I have sterile gauze placed into a sterile bowl with sterile saline. And I'm just allowing the saline to drip into the surgical site. And water. When passing hinged forceps such as needle drivers, as well as thumb forceps, there is full support of the instrument while it is being passed off. So I'm going to hand the scalpel blade, so making sure to provide full support, passing it with the blade turned out.
Needle drivers and suture cups.
So some of the duties of a sterile nurse are preparing the surgical tray for the surgery, as well as handing instruments off to the surgeon, possibly aiding and holding throughout the surgery, moistening tissues in the surgery, as well as whatever the veterinarian may require through the surgery so long as it is sterile. Maintaining that sterile and aseptic technique when fully gowned and gloved. The hands must stay away from the body. The elbows must remain up. Hands are not down. We must also be careful not to touch anything that is not sterile. So for example, I have a sterile surface here, but this table surface may not be completely sterile, so I'm not able to touch this. On myself, I am sterile up until about 2 inches above my elbows, and sterile from the level of my chest to about the level of my waist. So I have to be careful to keep my hands within that field, as well as to remain within sterile field. So when moving about, being careful with my body, making sure that I am aware of my surroundings, that I am not touching things accidentally that are not sterile. So now that surgery is done for the day, we will begin cleaning of our surgery suite. So any horizontal surfaces will get cleaned off. Anything on wheels will be pulled out of place so that they can be swept and mopped around. Any surfaces that were used, such as the surgery table and our prep table, will be disinfected. As well with the surgery table, we have to make sure to clean all the moving parts and get into the trough that is underneath of the table. Our monitoring equipment, such as our temperature probe, esophageal temperature probe, the alligator clips from our ECG lead, as well as our SpO2 monitor will all be cleaned off with alcohol, and all the wires on them will be cleaned as well. And then, as mentioned, the floors will be swept and mopped with their own appropriate surgery items. So any sharps being disposed of after surgery should be disposed of into a proper sharps biohazard container. Metal sharps such as the scalpel blade or needles from suture material should never be picked up with any of the other instruments, should only be picked up with a needle driver, as this is the only instrument that is designed to hold metal. That just is disposed of properly in the appropriate sharps container. So garbage from surgery is properly disposed of by placing it into a biohazard bag so that it is properly incinerated, as there is some biological material in that garbage. And then a company comes and picks that up for us. Okay, I'm demonstrating how to clean surgical instruments. So our instruments have been soaking in a detergent solution for about the last 10 minutes in some warm water. Placing some gloves on. Ideally, instruments should only be cleaned, or should be cleaned with an ultrasonic cleaner. Unfortunately, we do not have one, so they are cleaned manually. Only using a soft bristle brush, not a wire brush, so as not to damage the instruments. We are going to scrub every part of the instrument and paying very close attention to the box lock to make sure any blood, debris, or any gunk is not trapped in there. Then we can give it a rinse and place it into our surgical milk. And it sits in the surgical milk for about 30 seconds. And while it's sitting, I can clean another instrument. The previous instrument is then removed from the surgical milk, can be placed on a towel to air dry, making sure that the instruments are not touching one another and that they are spread apart. I'm going to wrap one of our soft tissue surgery packs. So my instruments are already nice and dry, and I've already sorted them into the order that our veterinarians prefer their instruments. I'm also including 10 gauze that I've already counted, along with an indicator strip to indicate whether or not this pack has been properly sterilized. And I'm ensuring that when my pack is folded that there are appropriate tabs so that when they are going to be opened, they may be pulled out easily. And to secure my pack, I am using autoclave tape that has tabs on either end. The autoclave tape begins out looking like regular Scotch tape, but does have bands throughout it that will turn black once it has been autoclaved. And then I will write the day's date and what pack this is. So this is our black surgical pack, and it is October 1st, 2015, and my initials. Alright, so I'm wrapping a surgical gown pack. So I have already taken a lint roller to my surgical gown to remove any excess hair. I'm beginning by making sure that my gown is the right way out. And then I'm pulling out a little bit of the arms on my gown to make it easier for when the veterinarians put the gown on. I then proceed to tuck everything into my gown. I'm making sure all of my strings are tucked in. And then I'm going to place it into an accordion fold. I'm going to tuck that off to the side for a moment while I prepare my hand towel. And this hand towel has also been lint rolled for any remaining hair. And it's also been checked over to make sure that there are no holes or anything of concern with either the gown or the hand towel. I'm now placing down my drape with my hand towel on top. I'm placing an indicator strip roughly into the middle of my pack. I'm using an envelope fold to wrap this pack. Again, making sure to leave tabs behind so that pack may be opened quickly and easily. I'm using some of my autoclave tape. I'm going to secure my pack and write on it what this is. So this is a surgical gown with a hand towel. Today is October 1st. And my initials. This is our autoclave. Our autoclave is a gravity air displacement sterilizer. So the way that this unit functions is that we place distilled water into our reservoir fill, which happens to be on the top of our unit. So we would place some distilled water into the top to a certain fill point. The water is then converted into steam, which pushes the air out of the unit. And once that steam reaches a certain temperature, it needs to be 121 degrees Celsius at 115 kPa. The cycle will then process for about 30 minutes to ensure proper sterility of our packs. The steam will then condense and then turn back into water. So that is how the sterilization process works for one of these units. When we are packing our autoclave, we need to ensure that everything is spaced out appropriately, that nothing is touching the sides of the autoclave, and that packs are not touching each other. So when the tray is loaded, packs should not be touching each other. They should not be stacked up one on top of another, because we do need the steam to properly circulate around the packs and then again condense back into water and not end up soaking our packs as it's condensing and leaving water on the packs. If we were using sterilization pouches, we'd want to make sure that the paper side of the pouch is down, that the plastic side is up. And for maintenance of our autoclave unit, we can do several things. On a weekly basis, we should be checking a couple things. We want to check our door gasket, make sure that it's nice and clean. We can also clean off our boiler ring. We also want to ensure that our door latch is functioning properly. We can also do a test to make sure that the cycle should not run if the door latch is not closed and locked appropriately. An alarm will go off for that. On every 25 cycles, the unit does also need a full cleaning. So in order to do the full cleaning, we have a piece of tubing that allows us to connect into our water reservoir to do a quick drain, removes all the water from the unit. We then place a cleaning solution into our reservoir along with a specific amount of distilled water. We run a cleaning cycle on the autoclave, then drain out the water again, fill it back up with some more water, and proceed to drain again so that we can remove all of the suds from our autoclave. While we're doing that, we can also take our tray and support stand out and give everything a good scrub and clean. So to tell that our autoclave pack is sterile, there is a couple ways that we can tell. First off is the indicator tape on the outside of the pack. So before, this was all the beige colored like Scotch tape, whereas now there are black lines running through it. So that does indicate that this has been autoclaved and sterilized. We can also check our indicator strip that is on the inside of our pack. And here we have our indicator strip that is indicating that it has been properly sterilized. So before, only the O was black, the K and the arrow were not, so those are now black. We also want to check in the middle of our pack, and our dot is black. It was not before, so that indicates that even within the middle of the pack was properly sterilized. Suture needles can come in a variety of different shapes and sizes. The most common shape that they're going to come in is actually some type of a circle or portion of a circle. You do see straight needles once in a while. They're typically used for oral hematomas, but most of the time it's going to be some degree of the circle, anywhere from a half to a quarter of the circle. The size of the suture needle is really largely going to be dependent on what suture material is going to be used and what size it is. So for our most common sizes, our 4/0 to 2/0, we're looking at 26 and 24 millimeter suture needles, whereas our ophthalmic suture actually has much smaller needles because you're working in such a small space. So our silk has a 13 millimeter needle, whereas our Vicryl has a 6.5 millimeter needle. Most of the suture needles are going to be swagged to the suture, so the suture material is directly connected onto that needle. Sometimes an eyed needle will be used if the suture material is on a spool. And there are several different types of shapes that come with these suture needles as well. And they all have pros and cons to them. So for example, PDS comes with a taper cutting needle, a taper point. There is no cutting edge on it, so you really have to push through the skin, which the vets feel does a little bit more trauma and is more difficult to work with. So for that reason, they really prefer the reverse cutting edge that comes with some of the monocurl sizes. It's just much easier to work with and much less damage is done to the skin. So the most common sizes that we tend to see are that taper point. There are blunt taper points, but we don't tend to work with those very often. You do have your cutting edges, your reverse cutting edge, which is a bitter cut. And then for our Vicryl ophthalmic suture, it actually does use that micropoint spatula suture, which really just gives very fine precision when you're working with such a small needle and is able to just cut through whatever material you're working with great ease. And those are the different sizes of suture needles that we tend to work with. There are several different types of suture patterns for a veterinarian to choose from. The most common that we see in our practice are the simple continuous, the simple interrupted, and a continuous horizontal mattress. Our text here only shows the interrupted horizontal mattress, where we will often see these used. The simple continuous is frequently used for subcutaneous sutures, so suturing the linea alba, the muscle layers, and just below the skin. This is great where you need good tight apposition of the tissue, and it has a knot on either end and then a continuous loop of the suture material between the two knots. The simple interrupted pattern is frequently seen for external stitches. The great thing about this is if an incision isn't healing properly, and when we see them back to remove the sutures, if we need to leave a couple of the sutures in, we have the ability to do that rather than pulling out the entire line of sutures. But great opposition from the simple interrupted sutures. It just is a little bit more time consuming than the simple continuous. And then lastly, we have the horizontal mattress, the continuous version, which typically we see the vets using for opposing the skin. The horizontal mattress, even though it does take a little bit longer, it provides better apposition in areas where there's going to be a lot of tension. So that skin, particularly in a spay incision, for example, having that extra strength in the incision at the level of the skin is really great. And it does help to create a very nice apposition for that skin to heal. Okay, so I'm doing stitch removal on this dog and having a quick look at the incision. The incision looks like it's healing great. There is no sign of any swelling with the incision site. There's no dehiscence of the tissues. Hang on, Keely. The sutures are not pulling apart at all. There is no oozing from the incision site. There is no sign of infection. So this incision is healing well and is ready for these sutures to come out. And I'm just using a little pair of suture scissors just to clip the suture and pull the stitch out.